Hello, and welcome to today's Clinician Call, Ongoing Risks of West Nile Virus, including risks during transplantation. This webinar is a joint effort between the American Medical Association and the Centers for Disease Control and Prevention. West Nile virus is the most common cause of mosquito-borne disease in the contiguous United States. Most people infected with West Nile virus are asymptomatic. However, roughly 20% of infected people will develop a febrile illness, and about 1% will develop neuroinvasive disease, such as encephalitis, meningitis, and acute flaccid myelitis. Of those with neuroinvasive disease, 1 in 10 will die. Those who are older and who have immunocompromising conditions are at higher risk for more severe disease and death. Although primarily transmitted by Culex mosquitoes, West Nile virus can also be transmitted by infected blood products and transplanted organs, often resulting in severe disease. In 2025, there's been a substantial increase in West Nile virus activity, with 41% more severe disease cases and 32% more deaths than what is typically seen with West Nile disease. In addition, CDC is currently working with multiple state health departments and clinical teams on possible transfusion, transplantation, and dialysis-related clusters. Today, we will hear about the latest epidemiology, best practices for diagnosis, and guidance for immunocompromised populations. I'd like to introduce myself. I'm Erica Kaufman-West, the Director of Infectious Diseases at the AMA. With me, there are several experts who have been tracking West Nile cases and outcomes. First, I'd like to introduce Captain Carolyn Gould. Dr. Gould is a board-certified infectious disease physician and medical officer in the Arboviral Diseases Branch, Division of Vector-Borne Diseases at CDC. Her primary focus is clinical consultation and investigation of arboviral disease cases in the United States. Today, Dr. Gould is going to give us an update on West Nile virus epidemiology, discuss the clinical course and diagnosis of West Nile infection, and spend some time on how West Nile virus affects special populations, like the severely immunocompromised. Before I hand it off to Dr. Gould, I want to remind our audience to make sure you log into the chat so you can ask questions that we can discuss with our panel live or be answered in the chat by West Nile experts. We'll do our best to get to as many as we can. Dr. Gould?
Thank you, Erica, and thanks everyone for being on the call. I'd like to thank the AMA for hosting this webinar and also thank Kelly Broussard and Dr. Lahaz in Texas for presenting as well. West Nile virus is the leading cause of domestic arboviral disease. It is in a RNA virus in the family Flaviviridae in the genus Flavivirus, and it was first detected in the United States in 1999, and since then has spread throughout the country. It is primarily spread by Culex species mosquitoes, and there are different species depending on the region of the United States you're in. And despite being in the US for over 2 decades, there are still no treatments available and no human vaccines, unfortunately, to prevent West Nile virus. Although mosquitoes are the primary route of transmission for West Nile virus, there are multiple other ways that West Nile virus has been transmitted. So organ transplantation, which we'll discuss in more depth soon. Blood transfusion, the risk of blood-borne transmission has been diminished substantially after universal screening was implemented in 2003. There has been 1 case of transplacental transmission reported associated with fetal abnormalities and 3 possible cases of peripartum transmission. West Nile has been transmitted through breast milk in 1 possible case that's been reported, and through percutaneous and conjunctival exposure in laboratory personnel and a field worker. So as I mentioned, West Nile virus was first detected in New York City in 1999, and rapidly, following that, rapidly spread across the country. And over the past decade or so, the incidence of West Nile virus disease has been highest in western and central regions of the United States, as you can see in this map, showing cumulative disease incidence between 2014 and 2023. There have been large outbreaks that have occurred in the southwest region of the United States, in Texas and Arizona. And in fact, the largest outbreak on record in the United States occurred in Maricopa County, Arizona in 2021, with over 1,400 cases and over 100 deaths reported during that year. Most cases occur during July through October, which is the primary season when mosquitoes are active. But in warmer regions of the country, you can see a longer transmission season beginning earlier in the summer and going into the late fall. And as Erica mentioned, West Nile case counts in 2025 have been higher than usual. So currently there are 48 states and the District of Columbia that have reported West Nile virus activity, with over 16 human disease cases reported so far, including over 1,100 neuroinvasive disease cases. The case counts, if you look at the weekly case counts reported over the past 10 years, we have 40% higher neuroinvasive disease cases and 40% higher numbers of deaths than compared to the 10-year median. And also, as Erica mentioned, we are working with multiple states to investigate possible transfusion and transplant and possible dialysis-related West Nile disease cases this year. And most years we have multiple investigations going on of transplant and transfusion investigations of West Nile. So if you look at where cases are occurring, this year, roughly half of all cases reported are from 7 states, with Colorado leading at 275. And this is as of October 21st, followed by Illinois, Minnesota, North and South Dakota, Texas, and Pennsylvania. But if you look at other states reporting cases, there are multiple states that have higher than their usual neuroinvasive disease case counts. So, for example, Kentucky and Illinois and Utah and other states have higher than usual numbers of cases, both disease cases and deaths reported compared to previous years. This is a busy diagram, but if you want to look at it further, you can look at the JAMA review that I have cited here. But this is an overview of the disease presentations associated with West Nile virus infection. Based on seroprevalence surveys, we know that about 80% of infections are completely asymptomatic. About 20% cause a febrile illness known as West Nile fever, and less than 1% of infections lead to neuroinvasive disease associated with a 10% fatality. And neuroinvasive disease can come in the form of meningitis, encephalitis, or meningoencephalitis, and acute flaccid myelitis, which can occur in conjunction with encephalitis. There are less common manifestations that occur, some of which involve infection of the eye, which is actually more common than we think. West Nile associated rash occurs in about up to 60% of patients associated with West Nile virus disease, and it's generally a maculopapular rash that affects the trunk and extremities. It's really indistinguishable between other viral exanthems or drug eruptions, and it tends to last about a week. So this is a diagram demonstrating West Nile virus pathogenesis. So generally, if you're infected by a mosquito, the virus is inoculated into the skin through the saliva of an infected mosquito, and it first infects keratinocytes as well as immune cells in the skin, dendritic cells, which are antigen-presenting cells, which then activate the innate immune response. So that can lead to secretion of pro-inflammatory cytokines, particularly interferon, type 1 interferons, as well as interleukin and tumor necrosis factor. And then those cells migrate to draining lymph nodes where the virus replicates and then enters the bloodstream and then can disseminate to multiple different organs, including the central nervous system in some patients. So as I mentioned, the initial immune response is the innate immune response that is responsible for controlling viral replication. And then the adaptive immune response is activated, which is primarily B and T cells, the humoral immune response, and that is important for clearance of the virus, as I'll show you in patients who are immunosuppressed, particularly patients who can't form antibodies have a very difficult time clearing the virus, but also the adaptive immune response is important for regulating the inflammatory response that can actually cause more damage. Neuroinvasion is mediated by a number of different potential mechanisms, including direct infection and penetration of endothelial cells, cytokine-mediated damage to the blood-brain barrier, and in some cases, immune cells can migrate across tight junctions. That's known as the Trojan horse mechanism. And the virus can also enter the central nervous system through axonal transport from peripheral nerves. And again, the immune response, the chemokines that are secreted are important for initiating migration of leukocytes into the brain to try to clear the infection. There are several risk factors for West Nile virus neuroinvasive disease, the primary ones being older age and immunosuppression. So older age, people who are 65 years or older have a 5 to 20 times the risk of neuroinvasive disease compared to those who are younger. The risk among those over 65 is about 2% compared to less than 0.5% for younger people. And that's likely related to age-related immune defects in the innate and adaptive immune response, as well as a decline in blood-brain barrier integrity, so more leaky blood-brain barriers in patients who are older. In terms of immunosuppression, there are deficiencies in type 1 interferon signaling that it can increase the risk, and they can be genetic or acquired with autoantibodies. It has been found that patients with severe West Nile virus disease have much higher proportion of them have autoantibodies against interferon compared to those who have less severe disease or who have asymptomatic infection. And that's also the case for other infections such as severe COVID, influenza, and yellow fever vaccine adverse events. Those autoantibodies against type 1 interferon seem to increase the risk for multiple infections, including West Nile virus. And older people have a higher level of autoantibodies than younger people as well. There are also deficiencies in antibody production, which can be genetic or more often acquired through the use of anti-B cell monoclonal antibody therapy, which I'll discuss in a moment. But drugs like rituximab that are increasingly being used can wipe out the B cell population and prevent somebody from making antibodies. That puts them at much higher risk for neuroinvasive disease and death. And then other immunosuppressive medications, such as anti-rejection medications in transplant patients, malignancies, especially hematologic malignancies, also being male, having diabetes, chronic kidney disease, and hypertension all increase the risk of severe West Nile virus disease. In terms of outcomes, I mentioned the overall mortality is 10%. In younger patients, it's lower, it's about 2% if you're less than 50, and it's over 20% if you're 70 or older. Immunocompromised patients have a much higher risk of neuroinvasive disease and death, and it can be 30 to 40% or higher, as I'll show you. Long-term sequelae are very common in patients who've had West Nile virus disease. 30 to 40% of hospitalized patients end up having to go to long-term care or rehab facilities, and more than half experience long-term symptoms and functional disabilities at over a year. And those are most commonly muscle weakness, fatigue, myalgia, memory loss, depression, difficulty concentrating, and difficulties with activities of daily living. And although sequelae are more common with neuroinvasive disease, they can occur even with West Nile fever. A lot of people with West Nile fever will go on to have fatigue and weakness lasting up to a month. In terms of West Nile in organ transplant recipients, we are aware of 15 transplant clusters associated with West Nile during 2002 to 2024. 13 of those occurred in the US and 2 in Italy. The infections in these patients acquired through organ transplant are associated with very high morbidity and mortality. So of 41 involved recipients in these clusters, 35 or 85% became infected with West Nile virus. And of those 35, 27 or 77% developed encephalitis. And 11 of the 27 or 41% died from the encephalitis. Most of the organ donors involved in these clusters were not screened for West Nile virus. It's not required for organ donors. 80% or 12 of the 15 were not screened, but on retrospective testing of banked serum or plasma were found to be viremic with West Nile. And so screening could have prevented at least 9 of these transmission events, which involved 15 cases of encephalitis and 4 deaths. One of the donors who was not viremic on retrospective testing was found to have West Nile RNA in spleen and lymph node tissue. So we do know that the virus can be sequestered in organs and tissues after the viremia has cleared. So the screening test is not perfect, but it can pick up the majority of these infections. 3 of the cases, and one you'll hear today, were screened, but again, were not found to be viremic. Some of those did have West Nile antibodies when tested later. And West Nile transmission, as I mentioned, is very seasonal, and all of these reported transplant transmissions that I mentioned did occur during the typical West Nile season, during July through October. So that points toward a potential seasonal screening strategy that could be very effective at preventing these. And most of the organ procurement organizations are not currently screening for West Nile virus. In a survey that was done in 2019 and 2020, 46 of 57 OPOs or organ procurement organizations were not screening for West Nile. Or I'm sorry, that were surveyed, 18 of the 46, or 39%, were screening for West Nile, and 17 of those were doing year-round screening, and 1 was doing seasonal screening. So less than 40%. Per FDA, all blood donors in the United States are screened. All donations are screened for West Nile year-round, and all living donors of human cells and tissues are screened on a seasonal basis during June through October. There is currently a proposal by the UNOS Organ Procurement and Transplantation Network to perform seasonal West Nile screening among all organ donors living and deceased. And that is, if you go to that QR code, you'll see the public comments that were submitted on that proposal. The public comment period is currently over, but if you're interested in reading some of the comments, you can go to that website. So on to B-cell depleting monoclonal antibodies. This is just a schematic of the different generations of antibodies that have been developed over time. The first generation one, rituximab was the first one. There are several biosimilars. These target the CD20 antigen on B cells. Newer generations, the second generations, are more humanized, and those include ocrelizumab, which is currently approved for treatment of MS, and ofatumumab. Third generation antibodies include ublituximab, obinutuzumab, and inebilizumab, which targets the CD19 antigens on B cells. Rituximab is the prototypic B-cell depleting monoclonal antibody that was first approved for treating non-Hodgkin's lymphoma in 1997. It's been since approved, its approval has been expanded to many, many other conditions, and it's widely used off-label for autoimmune and inflammatory conditions, as are some of the newer generation antibodies. But once you get an infusion with rituximab, 90% of the circulating B cells are killed within 3 days of the first infusion, so it acts very quickly, and you have near complete B cell depletion that persists for 6 to 12 months. In some cases, it can last even longer. So stopping these drugs, it still will take a long time for the B cells to be replenished. We published a review of arboviral neuroinvasive disease cases in patients on rituximab a couple of years ago, where we were starting to see these cases reported in the literature, and we had cases coming to our lab for diagnostics. And so I just wanted to go over some of the main features. So there were a number of different arboviruses, both mosquito-borne and tick-borne, that were identified in these patients, the majority of which were West Nile. The clinical syndrome in 86% of the patients was encephalitis or meningoencephalitis. Some of them also had acute flaccid myelitis or paralysis associated with that. The outcomes were very bad. 71% of patients died. Among all the survivors, they all had long-term disabilities and dysfunction. The key thing with these patients is that diagnosis most often needs to be done by molecular testing. So either RT-PCR testing, or metagenomic next generation sequencing, or some sort of molecular testing, viral culture, or tissue diagnosis. Most of these patients did not produce antibodies, IgM antibodies against West Nile or other viruses. So it has to be diagnosed differently from the way we diagnose most immunocompetent patients. Also, some of these patients had very protracted, chronic, debilitating neurologic presentations that took a long time to present and be diagnosed, even a year after initial symptoms, and some of them presented outside of the normal arboviral season. Some of them were thought to have prion disease. Some had severe brain atrophy. So these are some of the things that we're starting to see in these patients presenting very atypically, and something you need to think about if you have a patient on one of these drugs and they're presenting with a neurologic illness, that it could be a chronic viral infection and possibly an arboviral infection if they've been potentially exposed to ticks or mosquitoes. After we published that review, there have been additional reports that have been published on patients with MS on ocrelizumab, with West Nile neuroinvasive disease. In this case series, there were 4 patients, all of whom had West Nile meningoencephalitis. The authors calculated the odds of having West Nile neuroinvasive disease in this population and found that it was 258 times that of the general population in the region. Interestingly, some of these patients were able to produce West Nile IgM antibodies. 2 of them were diagnosed also with metagenomic next generation sequencing of CSF. So I don't know if there's something different about ocrelizumab that allows patients to more commonly produce IgM antibodies, but it's a little bit different from what we saw with the rituximab. All of these patients survived but had residual neurologic sequelae at 8 to 18 months. So in summary, arboviral disease in patients on B-cell depleting monoclonal antibodies can have atypical, severe clinical presentations with high mortality. Seasonal onset may not apply as the disease can be protracted. And most of the patients that we have seen have not been able to produce serologic responses, but need molecular testing, which may need to be, requested through the state health departments or through some commercial labs are doing this type of testing. But it's very important as you're seeing these patients to counsel or prescribing these drugs, if you're a prescriber, to counsel patients about mosquito and tick prevention. It's often not on the radar for people because they're also at risk for other infectious diseases. But many people don't think about arboviruses in these patients, but it is starting to be a big problem. So just going quickly into diagnostics, I wanted to show this diagram in patients who are not immunosuppressed to demonstrate that viremia is very short-lived once symptoms develop. It may only be present for 1 to 2 days. IgM antibodies get produced pretty quickly, and most patients by 8 days will have West Nile IgM antibodies. So it's very hard to detect viremia in these patients. The sensitivity of RT-PCR on serum and CSF is very low. But IgM is the mainstay for diagnosis in non-immunocompromised patients. So this is, again, a busy diagram, but I just wanted to show you, you can go to our testing algorithm on the website there or find it in the JAMA review. But this is a testing algorithm where we divided patients with immunocompromise from those without immunocompromise. And just to demonstrate that you may want to consider West Nile RNA testing, either through RT-PCR testing or metagenomic sequencing in some immunocompromised patients, as well as IgM antibody testing. Whereas with patients without immunocompromise, IgM testing is the primary way to diagnose it, either in serum or CSF. You can diagnose West Nile by serum testing, you don't necessarily have to have CSF. And if the IgM is initially negative on acute testing, you want to repeat that IgM testing on or after day 8 of illness to ensure you've left enough time for a patient to develop an immune response. In some cases, if you have a positive IgM result, you'll want to do confirmatory testing, which involves neutralizing antibody testing with PRNT or plaque reduction neutralization testing, which can be done at some state public health labs or at CDC. In some situations where you'd want to do that is if there are other related flaviviruses circulating that the patient might have been exposed to, and you need to distinguish between the two. An example would be Powassan virus, which is spread by ticks in certain areas, or dengue virus, if you're in a dengue endemic area, or St. Louis encephalitis virus. So in some cases, you'll want to ensure it's West Nile. Also, if it's a death or a severe or atypical case where you're not sure what's going on, or if it's a case that you suspect might be transplant transmitted, in which case you really want to make sure you know what you're looking for, what the patient has in terms of determining the source. We have had cases, investigations where, for example, it was initially thought that a symptomatic recipient had West Nile, but they ended up having a different flavivirus, and that was really important both for epidemiologic purposes and for the purposes of determining the source. Clinical management, unfortunately, as I mentioned, there are no proven therapies for West Nile virus disease. We did a review of the literature that you can find on our website, and I will go through some of that with you on the next slides. But the main thing is supportive care. It's very important to monitor patients with encephalitis for increased intracranial pressure, airway compromise. Seizures are only present in 3 to 6% of patients, but it can happen. Patients with acute flaccid myelitis should be monitored closely for neuromuscular respiratory failure. A lot of people try IVIG and ask about IVIG, and so far the data is only case reports and case series, and the results are highly variable. The patient populations and the timing and the dosing very variable, so it's really hard to know how effective it is. Theoretically, it should be effective in patients who are severely immunocompromised, especially those who can't produce antibodies if they're on rituximab or a similar drug. And we have had some cases where we have seen clearance of viremia in patients on rituximab who were given IVIG. But it's also important to consider the source of that IVIG because you want it to have West Nile neutralizing antibodies for it to be most effective. So ideally, it would be sourced from an area that has a fair degree of West Nile incidence. So that's one thing to consider. This is a table just of the major clinical studies that have been done on candidate therapeutics for West Nile virus disease. And the first thing you might notice is there aren't that many of them. Again, you can find this in the JAMA review in the supplement or on our webpage. But not very much. There have, in terms of the therapies that have been studied, include IVIG with high West Nile titers of neutralizing antibodies. There's a product that's not currently available in the US, but it is out of Israel. And the study that was done was a phase 1/2 study comparing that product to standard IVIG or normal saline in 62 patients with West Nile neuroinvasive disease. And there were no differences. It was primarily, the primary endpoint was safety and tolerability, and there were no differences there. So it seems to be safe. But they also saw no differences in functional outcomes or mortality. But the study was not powered to really assess outcomes like that. There's also a West Nile monoclonal antibody product that's not available in the US. It went through a phase 1 study in 40 healthy adults. There were no differences in safety or tolerability. The phase 2 study was initiated, but unfortunately had to be terminated because they couldn't enroll enough patients. But they did have 13 patients with West Nile fever or neuroinvasive disease. 2 out of 6 of the patients died in the treatment arm, and 1 out of 6 died in the placebo. So that's just the raw data. Really can't make any conclusions from that. Interferon alpha 2 B was studied in an unblinded randomized controlled trial among 23 patients with West Nile neuroinvasive disease. And there did appear to be greater neurologic improvement with interferon. This was only published in an abstract form. There was some treatment-induced neutropenia and hepatitis that resolved when the treatment was stopped. So that's just something to think about. I did see, I looked at the NIH clinical trials website and saw that there is another study of interferon that's currently enrolling in Israel. So hopefully we'll get some more answers about interferon from that. Steroids don't seem to work at all based on an observational and a systematic review and meta-analysis. So there was an observational study of steroids in 65 patients with West Nile neuroinvasive disease, and there were no differences in in-hospital mortality or sequelae. In a systematic review and meta-analysis of 281 patients with viral encephalitides of all kinds, including 33 with West Nile, there were no differences in survival. I did include a case series for a ribavirin just because it was a larger case series than most, 233 patients with West Nile disease. Unfortunately, there were higher rates of death with the ribavirin, but that was likely related to treatment bias. And so really can't say anything other than it probably doesn't work. There have been, if you look at preclinical studies, there are a lot of different agents that have been looked at, both in vitro, in vivo, and ex vivo that have activity against West Nile, but none of these have reached human clinical trials at this point. So we do need those trials to see if any of these agents might work. And these are just some of the examples, not all of them, but they include inhibitors of viral replication like nucleoside analogs. A lot of people ask about remdesivir, and that has been tried in some cases, but we just don't have the data to know whether it's effective. Small molecule inhibitors, lipid metabolism inhibitors that can disrupt the viral envelope, protease inhibitors. There's actually a few papers that look on minocycline that look somewhat promising, possibly related to minocycline's anti-inflammatory effects. GM-CSF seems to be effective in mice who are infected with West Nile based on activation of the microglia in the mice brains. One of the things that we really need to do is have more rapid and sensitive diagnostics, both for diagnostic purposes, but also to have clinical trials. So in order to see if any of these agents work, we need a way to rapidly identify patients with West Nile virus disease quickly. A promising type of test is RT-PCR of whole blood or urine, and most labs do not have validated protocols for these specimen types. As I mentioned, RT-PCR for serum and CSF in immunocompetent patients is very insensitive, but it seems to be much better with whole blood and urine. Some labs can do this. For example, the New York State Wadsworth Center can do this type of testing, but hospital labs could also work to validate protocols for this type of testing, especially if a clinical trial was initiated. It seems to me that based on looking at the pathogenesis of West Nile virus infection, that the timing of therapy can be very critical in terms of the mechanism of action and the status of the infection and the immune response. So I think timely and sensitive diagnostics are greatly needed. So since we don't have proven treatments, prevention is really key, and that involves personal protection measures, as well as community and household level control involving larvicides and adulticides. A lot of people don't use personal protective measures, but it's very important to counsel your patients, especially if they're immunocompromised or older, to really try to prevent infection using repellents and clothing, and avoiding being outside during high mosquito times, screens and windows, and air conditioning. We are trying to advocate for more prophylactic agents. We wrote a vaccine perspective advocating for further development of West Nile virus vaccines. There have been at least 7 vaccine candidates that have started in clinical trials, but were stopped quite a while ago, mostly related to lack of financial incentives. So that would be really important to work through. And also thinking about monoclonal antibody prevention in certain populations prior to a West Nile season. There've only been preclinical studies on that, no human studies, so that would be another potential way to move forward with prevention. So what can you do about West Nile and other arboviral diseases? I think one of the things, the main thing is thinking about it when you have a patient who might have a clinically compatible illness, to obtain the right and the appropriate testing to facilitate diagnosis and prevent unnecessary testing and treatments like antibiotic treatments. Also, once you diagnose, the lab diagnoses an arboviral or West Nile infection, it gets reported to public health departments so they can start initiating prevention measures, knowing what's circulating in the area. It's also important to do request confirmatory testing on any unusual cases, cases that are atypical, or cases you might think might have been spread through organ transplants, for example, or cases that you think need specialized testing that you can't get done at a regular, with commercial testing. And that can be requested through your health department, and in some cases, samples can be sent to CDC if needed. But again, reach out to your state health departments. You can reach out to us directly in the arboviral diseases program at the email below, which is our clinical team email, about any cases that are unusual or atypical or you think might have been transmitted by a non-mosquito route. And I think that's my last slide, so I will stop there. Thank you very much.
Thanks, Dr. Gold, for that overview and for some really practical tips on diagnosis of West Nile. I want to introduce our next guest. That's Kelly Broussard. Kelly graduated from the University of California, Berkeley's Master of Public Health program with a focus on infectious diseases epidemiology. At the Texas Department of State Health Services, she serves as a senior zoonotic disease epidemiologist. There, she serves as the state ArboNet coordinator and a subject matter expert on a variety of vector-borne and other zoonotic diseases. Kelly has overseen a variety of investigations and guided public health action in response to potential transmission of zoonotic agents via blood, organs, or tissues, including multiple West Nile virus investigations. Today, she's going to take us through her investigation of a recent transplant-associated West Nile virus cluster. Kelly?
Thanks so much. So I'll go ahead and get started. So as I said earlier, we'll be going through the overall investigation process here in Texas, kind of the state perspective for those of you so you understand how that sausage gets made, the specifics of our investigation in 2024, and our conclusions. So the overall process here in Texas. As Dr. Gould very expertly outlined, there are a lot of risks when you have donated blood products, tissues, and organs, and many of those are zoonotic in nature, despite the existence of really thorough donor screening efforts that are in place. West Nile is a bit unique in its concern, and part of these reasons include that West Nile screening is not required, as Dr. Gould pointed out. PCR or a NAT test is not always the tool that is utilized for screening. Sometimes it is simply an IgM test, which may not indicate acute active infection, and possible viral persistence in the kidney and other organs. And last but not least, the increasing amount of United States cases, which exposes more folks who could be possible organ donors. In the last 10 years, we have had 3 of these kidney-related investigations for West Nile in Texas, and they're quite complex. I'll go through more details on the next slide. And you can imagine we're a big state. We have 254 counties, and less than half of those counties have their own local health department. So you see on the far right, local health departments have a really crucial role in a home rule state like ours in doing the local health investigation of their patients. However, they can't be the experts in everything. They have to wear many hats. And so our role at the central office of the state health department, and I represent the zoonosis control branch you see on the left, is to help be that conduit of expertise and nuanced information when we're dealing with these very rare and unusual investigations. So us in the central office, we often receive the initial results, whether they be on the donor or recipient, to realize that there may be a transplantation investigation afoot. We communicate with blood and tissue banks, organ procurement organizations, as well as our colleagues at CDC, and sometimes these cross state boundaries, and we coordinate with other colleagues at other states. And last but not least, we have really crucial team members that are in our regional areas. So we have, as such a big state, a bunch of regions with regional teams that are part of the state health department to help us get all this work done. And they may serve as the local health department investigators when there is not a local jurisdiction in that particular area. So those teams can include zoonotic control individuals as well as healthcare associated infection team members. And they're really crucial because of their expertise and level of knowledge in how these types of medical procedures work and the screening procedures in place. They're really helpful for tracebacks and all the details we need to get from IPs when we're starting these investigations. So some of our main goals is repeating and performing additional testing in public health labs because we want to make sure we are really confident, like Dr. Gould said, that we know what is infecting the recipient or the donor, and that we can assure if other recipients have also been infected. We have to identify all possible affected recipients, trace them back, and determine their current health status. And we need to assess the risk of natural versus what I might call unnatural or organ-based exposure. So the visual here on this slide, I like to think of it as it's no easy answer. We have to take the information that we have and make the best interpretation we can. Sometimes we cannot conclude whether it was natural exposure through mosquito or an organ transplantation. So in the example of West Nile with an organ transmission event, some of the instances where we see more evidence for natural transmission would be when the patient has a significant amount of mosquito exposure. We're a highly endemic state for a very long part of the year. Sometimes there may be multiple recipients from the same organ donor, but only one recipient is affected. So that kind of reduces the overall interpretation that there is a really clear infectivity from the donor. And sometimes we have weak lab or clinical evidence in the donor of actual West Nile infection. So for example, we had a case where the person was an accidental drowning death and their organs are donated. That does not strongly imply death due to West Nile disease. And it turned out that we were able to rule it out in that situation. Now for organ transmission, to definitively prove that's happening, what we often really try to get is genetic details from our investigation that can actually connect the dots between either two recipients, multiple recipients, or the donor and a recipient. There are also examples where the recipients, often due to the nature of their severe medical conditions, have essentially no outside exposure because they are permanently hospitalized during the entire incubation period. So I won't go through this next part too much because Dr. Gould did such a beautiful job on all of the testing out there, but they all have their pros and cons, and these are really part of how we have to take all the information that's available. And sometimes we're not able to have a test result we'd like to have, and we just have to take the best interpretation that makes sense for the situation. So now I'll get into the timeline of this investigation. So there's a little bit of color coding to kind of help you visually have a guideline here. The green boxes are kidney 1 recipient, yellow boxes are kidney 2 recipient, and the blue boxes are key public health actions. So we first have our organ donor. This individual presented in June 2024, and may I add, 2024 for Texas was the highest West Nile year we've had in a decade. So there was a lot of exposure going on. And this individual presented for care with neurological symptoms. They then expired from the illness, but the OPO did perform West Nile NAT-based screening, which was negative. So the donor proceeded to donation. Both the kidneys as well as the liver were transplanted into recipients. 23 days later, kidney 2 recipient had the onset of encephalitic symptoms. A few days after that, the same recipient, we were able to confirm PCR evidence of confirmation of West Nile infection in this recipient in CSF, and this was duplicated at the CDC lab after being initially done at the commercial lab, as well as IgM positivity. A few days later is when the public health connect the dots really came together, and our teams were able to notify us, and we started this whole look back investigation. On day 42, as part of their normal transplantation post-op procedures of double checking that they were okay, especially given this situation. Thankfully, the liver recipient remained well and had no lab evidence of infection with West Nile. And on day 82, we were able to confirm infection in the donor. And this did not show any evidence of systemic viremia in the serum, but it did show serologic evidence of infection with antibodies. And on day 84, the kidney 1 recipient, the other person, was IgM negative, but PRNT positive as CDC, was still well. And the interpretation at that time in that context was it was likely a prior exposure earlier in their life to West Nile, given the lack of illness and the lack of IgM, even though they are immunocompromised. So the liver recipient stayed well, stayed PCR negative, great. Unfortunately, kidney 1 recipient, about 5 months after the transplant, had the onset of encephalitis. So that is about the longest we've ever seen. That's not been documented really to be that long before in terms of incubation for a transplant-associated infection with West Nile. And here is where our lovely next speaker, Dr. Lahaz, comes in. He and his team treating this patient reached out to public health for a consultation on this patient's illness, concerned about rabies given the neurological symptoms that were presenting. And this recipient was IgM positive for West Nile at a commercial lab shortly thereafter. So we were starting to see some stars align that it might actually be the kidney, it might be West Nile. Unfortunately, the other recipient did expire from their illness shortly thereafter, but that's around the same time that we were able to rule out rabies with testing and clinical consultation through CDC and kidney 1 recipient. So that really left West Nile as the primary concern. And that information was locked down with some really helpful metagenomic sequencing testing that was at a commercial lab on kidney 1 recipient. And this was in CSF. So very strong evidence of that confirmed infection. They then sadly also expired from their illness. And we spent some time trying to coordinate the information that we had. Like I said, put those puzzle pieces together. And our colleagues at CDC worked so hard and did an amazing job at their laboratory analysis to be able to go back, look at all the specimens that were available. And they were able to find a really low level viremia in a prior to onset specimen that was a serum specimen in kidney 1 patient. So that was really shocking news because it showed that they had this low level viremia prior to onset. And thankfully, the commercial lab was really generous and cooperative and provided us their raw sequence data so that we could look into that because the specimen was not available any further. So I'll walk you through what we made of all that. So don't be scared of this big table. What I want you to take away from this is this square right here. So basically, we had one sample from kidney 2 recipient that we actually had genetic information that we could sequence. We had a couple of samples from kidney 1, but the question is, how can we connect them? We had no PCR positive samples from the donor. We did the best we could. And CDC's work and the commercial lab being cooperative with our investigation allowed this really helpful conclusion to come forth. Basically, you don't see a 98.8% overlap in sequence between 2 completely unrelated natural exposure events through a mosquito bite. So this evidence was really, really strong. So I'll walk you through kind of the overall conclusions here. So like I said earlier, both the kidney recipients and the donor, we were able to confirm West Nile neuroinvasive disease in those individuals. The donor did pass NAT-only screening, but the donor and recipients all had natural exposure to mosquitoes due to the endemic area and time of year. The liver recipient thankfully did not become infected. The kidney 1 recipient did harbor a subclinical low-level West Nile viremia at least 2 months prior to their onset. And additionally, that onset was 5 months after transplant, which is the longest that we are aware of to have been documented for this type of investigation. The West Nile strains in each kidney recipient were highly related based on the genetic analysis that CDC performed, and that was compared to publicly available West Nile genome data. So those small changes that we do see are better explained by replication within the patients than natural separate exposure events. And there's some resources there. So hopefully I gave Dr. Lahaz plenty of time for his really interesting clinical talk. Thank you.
Well, thank you very much. Many thanks to the organizers for the opportunity to speak. So I'll be presenting our case, and I would like to acknowledge the contributions of Dr. Emily Wong, that was the 2024-2025 Transplant Infectious Disease Fellow at UT Southwestern, and she's currently at UAB. So we have a 60-year-old, a man in his 60s with a history of a deceased donor kidney transplant that he's presenting with fevers and altered mental status about almost 6 months, almost 6 months post-transplantation. 2 weeks prior to admission, he experienced nausea, vomiting, and diarrhea. 1 week prior, he presented to another medical facility where he received IV fluids for a presumed gastroenteritis. 4 days prior to admission, he develops a fever, and then he's admitted due to generalized weakness until 2 days prior to that, he was able to perform all his activities without any limitations. When we initially evaluated the night of admission, he was answering questions and completely oriented, and had reported that the GI symptoms had resolved and fever was the only reason why he was there. Unfortunately, within matters of hours, his neurological status rapidly deteriorated and he had to be intubated for airway protection. His past medical history, like I said, is most notable for a deceased donor kidney transplant. He received induction with anti-thymocyte globulin with a total dose of 4.5 mg per kg. You can see his CMV, EBV, and toxoplasma. Serologies, his initial immediate post-transplant course was complicated by delayed graft function requiring hemodialysis. He had a mild episode of CMV anemia, and after valganciclovir was discontinued. And initially, the plan was to have him on letermovir, but we had to return to valganciclovir. His maintenance immunosuppression included belatacept due to some findings on the donor kidney biopsy. He has a history that's also notable for type 2 diabetes with a A1C prior to transplant of 5.7. His immunosuppression, he was on mycophenolic acid 180 milligrams twice daily that we held upon admission, 5 of prednisone, and he was on belatacept. The last dose was given about 2 months prior to presentation. He was just on standard prophylaxis with Bactrim and valganciclovir. And you can see the list of his other medications. Going to his social history, we had to obtain the social history from his wife because by the time that we were evaluating him, he was intubated. He was born in Texas. He had never been a resident of the western part of Texas, in particular the Permian Basin or the Rio Grande Valley area. Has a cat. He really doesn't interact with the cat because the cat stays outdoors mainly. He didn't have any farm animal exposures, but he did hunt deer and raccoons. In particular, he kills and cleans the raccoons and distributes the game meat. He last hunted deer and raccoons just a couple of weeks prior to admission, and it's important to note that he performs this hobby regularly. And you can see the rest of his social history. So the initial examination that we performed prior to the intubation, he was obtunded, non-responsive to voice. He only responded to pain and withdrawals to pain. There were no gross ocular findings. There were no findings on ENT, respiratory, cardiovascular, or abdominal exam. He had no lymphadenopathy. There were no rashes. He was resisting movement of his head and eye opening, but there didn't appear to be any knuckle rigidity. We did notice some unusual resistance on the upper and lower extremities on passive movement. There was no clonus, but there was a mild tremor. His labs were probably more notable for a lymphopenia throughout the preceding weeks to his presentation. Post-intubation, his neurological exam, he had no hypertonia, no rigidity. He was not moving to painful stimulation. His pupils were pinpoint but reactive. The vestibulo-ocular reflex was absent. There was a corneal reflex, but there was no cough or gag reflex, and there was a subtle nystagmoid movement of the eyes. We also tried to stimulate with a draft of air, but there was no laryngeal spasms and no history of hydrophobia or aerophobia on the physical exams. His reflexes were mute, and his vital signs were quite labile, having episodes of severe hypertension, was on a drip to maintain normal tension. So these are the results of his MRI, and there were the main findings were in the white matter, where we could see diffuse restriction in the corpus callosum and also subtle diffusion restriction in the bilateral centrum ovale. We performed a initial lumbar puncture in which you can see that there was pileocytosis. We corrected the white cells for the RBC seen on the lumbar puncture, and he had about 250 cells, predominantly neutrophilic with elevated protein. We repeated another ALP a few days later. The pleocytosis had decreased, and now there was almost the same amount of neutrophils as lymphocytes in the lumbar puncture. Just going to show you some of the pre-transplant serologies, mainly because on labs he also had a certain degree of hepatitis. He had prior immunity to hepatitis B as well as hepatitis B. He was HSV2 IgG positive, but HSV1 negative, and his TB IGRA was negative, as well as his syphilis testing. Because he presented with fever, we performed a workup for the different abnormalities that he was presenting, both hepatitis, diarrhea, as well as encephalitis. You can see that the workup for parasites, enteric, viral pathogens were negative. He had a cat, so we tested for Bartonella, also tested for Coxiella, Toxoplasma, given his exposure to different animals, Cryptococcus serum antigen, and a West Nile PCR in plasma that was negative. And you can see the rest of the testing since he resided in Texas. We were also excluding coccidioidomycosis, histoplasma, as well as blastomycosis, because we can see we are an endemic area for all of them. So on his CSF studies, given the prior episode of CMV, the anemia, and because he was on belatacept, we tested for CMV. It was not detected, and enterovirus not detected, as well as Toxoplasma, HSV, and BCV, and Cryptococcus in the CSF. Given his exposure to raccoons, we consulted with the Texas Department of Health as well as CDC, and he was tested for rabies in different modalities, both serum, CSF, saliva, as well as knuckle pad biopsy, and they were all reported as negative for the respective tests. As it has been mentioned, we had clearly marked his chart as somebody that was involved in a potential donor-derived transmission event. We were notified, and we evaluated the patient, our patient, and he was asymptomatic at the time. And then again, as it was been mentioned, our patient was presenting close to 6 months post-transplantation. But there were many things that made us consider the possibility of West Nile. Number one is that it's always important to think about where is the pathogen coming from in transplant recipients. It could be community acquired, and that had been a year in which there was a significant amount of West Nile in Texas. But we had to also consider the possibility of a donor-derived infection, given that we were already notified. What was notable is that most of the donor-derived transmission events gives us at least a range of presentation between 13 to 15 days post-transplantation, but really there's even been description up to 46 days. We're almost at 6 months post-transplant, But at the same time, we have to acknowledge that most of what we've learned about donor-derived West Nile virus really comes from a really robust system, but relies on passive reporting of the cases. So there could be some selection bias on just clinicians thinking, hey, I'm just going to report this one because it's early post-transplant, but may not report later events because they're perceived to be acquired in the community. Another important thing that we considered is that there are several studies that have described the presence of West Nile virus RNA and even viral particles in urine years after the initial event. And although this is of unclear significance, our recipient was a kidney recipient. And the other thing that is also important to note is that much of what we know about donor-derived West Nile virus probably predates the widespread use of belatacept, which our patient was on, that could be considered a novel immunosuppressant agent. So for those reasons, we tested for West Nile virus. The serum, as it's been described, was positive for IgM. The CSF was also positive by IgM and positive by metagenomics, and then later confirmed to be donor-derived in nature. So that's the end of the presentation. Thank you very much for the opportunity to present today.
Thanks, Dr. Lahaz and Kelly both. They're super fascinating to hear about the case and to hear about how these investigations get to occur and how they, can move within a state and from the local to the state and then involving CDC. So thank you both for sharing this case and your experience. I know we're right up against the time. We got a really great question in the chat that I wanted to see if Dr. Gould could answer for us. This is from Lee. Does asymptomatic or mild infection confer any long-term immunity for patients?
That is a great question. We believe that infection, whether asymptomatic or symptomatic, does confer lifelong immunity to most people, patients who are not immunocompromised. It's hard to know with the asymptomatic cases. The way we know that people usually don't get reinfected is we don't see those cases, except with the exception of immunocompromised patients, there may be potential for reinfection or even relapse of a prior infection if it was never cleared. Yeah. Thanks.
And then I want to do one last question because I know it's been at the top of my mind too. Do we know why we're seeing an increase in case numbers, especially the severity this year?
So we can't say exactly why. We know there are some factors that could be in play that affect mosquito abundance and mosquito longevity and their geographic range. And those are things like moisture, increased precipitation. It has been a very rainy spring for much of the country, particularly in the Midwest and the western states where we're seeing higher numbers, and longer, summers, warmer winters, wet, rainy springs, those sorts of things likely increase the abundance of mosquitoes infected with West Nile. But there are other factors such as, bird immunity and, human activities and things like that. There have been a lot of attempts at modeling to try to predict where West Nile outbreaks are going to occur. And unfortunately, none of these climactic factors have really been predictive. They're difficult. The only thing that was predictive in the models was prior human cases in an area, which is predictive of future human cases. So, but we do know that, climate variables definitely impact the likelihood of having a lot of mosquitoes that potentially could spread West Nile.
Well, this has been fascinating for me, and I'm sure for our audience too. And unfortunately, that's all the time we have today. So I want to thank everybody in the audience for their interest in this topic, and thanks to all of our speakers for sharing information on what's clearly still an unfolding situation. I'm sure we'll all still be looking for more information as data is collected and analyzed and shared. And I think I speak for all of us when we say that we appreciate you and all that you do. If you're interested in obtaining a certificate of participation for watching, just click on the Take Quiz button or the link that's being shared in the chat. Stay safe, everyone.